Hello everyone, it's lovely to be here, lovely to see some familiar faces and some new faces as well. So, thank you for the introduction. I'm Michelle MacKintosh, I'm a gynaecology consultant. So I'm a gynaecology consultant just up the road at St Mary's, and I'm going to be talking to you about updates in surgery for ovarian cancer. You working okay? So I've been a consultant at St Mary's since 2018. One of my areas of specialisation is ovarian cancer surgery. I also do lots of other areas of gynaecology. I know my way around a cake knife and a surgical knife because we do lots of long operations that need lots of fuel. I trained at St Mary's and also at the Christie and also a specialised hospital in Germany called Kliniken Essen-Mitte, which is about the limit of my German. And it was there that I learned various advanced ovarian cancer techniques that I then brought back to St Mary's, and I've trained other members of our team. So we at St Mary's are a European Society of Gynaecology certified centre for ovarian cancer surgery. And as you just heard, I also have a role with our Royal College. So all of the different specialties of medicine have their own Royal Colleges who are responsible for developing the curriculum and international collaboration and assessing doctors in training. And so my role with them is ensuring the quality of training of subspecialists of the future and making sure that they're being trained appropriately and that they're doing everything they need to be doing. And so I'm just going to run through a few different subject areas. I think I'd like to talk about what the place of surgery is, and for different people that's going to be different, and at different times in your journey that's going to be different. What the evidence for surgery is, how we can make surgery safer, and what the future of surgery for ovarian cancer is. So I think, we'll start with a bit of background. How did we get to where we are now? So the first recorded surgery for ovarian cancer was back in 1809. But the first operation to remove ovarian cancer wasn't documented until 1872. Unfortunately, the advent of washing hands and anaesthetics reduced the mortality from 50% to 11%, and that is much lower now. It's not 11% anymore. You'll be delighted to hear we continue to make some improvements. So the first chemotherapy drug for ovarian cancer was documented in 1956, and it was 20 years after that that platinum chemotherapy, which as I'm sure many of you will know, is now a mainstay of ovarian cancer treatment, was first used. The BRCA genes, BRCA1 and 2, which are two of the key genes that increase people's risk of developing ovarian cancers, weren't discovered until the 1990s. And many of you will also be aware of PARP inhibitors or taking PARP inhibitors, and these weren't approved until 2014. So we've been using these for just over 10 years, and they are now also a cornerstone of our ovarian cancer management. So that talks about the drugs, but it doesn't really talk about the surgery. What is the place of surgery for ovarian cancer? And I'm conscious that that might be slightly different for all of you, and it'd be slightly different for different types of ovarian cancer, for different stages of ovarian cancer, for people that are different ages or at different stages in their lives. But there's lots of different potential reasons we might do an operation. So we might do a diagnostic operation to take a biopsy if we don't know what the problem is that somebody has. We might do a fertility sparing operation if somebody has a localised ovarian cancer and they want to retain their fertility and they've not got one of the higher risk subtypes of ovarian cancer. What you've probably got some understanding of is what we now call maximal effort cytoreductive surgery, which basically means doing very big operations for advanced stage ovarian cancer because we know that that gets the best outcomes. We might do an operation to facilitate ongoing treatment. So one of the more rarer types of ovarian cancer is a germ cell cancer, and we know that actually surgery's got less of a place in the management of germ cell cancers than chemotherapy has because they're exquisitely sensitive to chemotherapy. So we might do an operation to remove a large ovarian mass or to get a diagnosis to then get them onto chemotherapy. Or if somebody presents with a bowel blockage, we might do an operation to resolve that issue so that they can start chemotherapy treatment. There's also a role for surgery in recurrent ovarian cancers, and I'll go on to talk about that in a bit more detail later because I'm sure it's of interest. And there's also sometimes a role for surgery to relieve symptoms, palliative surgery. So I'm going to focus most of my discussion on cytoreductive surgery, maximal effort surgery, because the most common scenario in which we're having this conversation and where a lot of the research is focused is in, the subgroup of people that present with advanced ovarian cancers, such as high-grade serous cancers, that is presented at a later stage, and surgery is more than just, perhaps what might be a keyhole operation or an operation where we might only need to remove one ovary, which is still awful in itself, but better than some of the bigger operations that we have to do and that you may have had. So there's been increasing evidence to support the extent of surgery since the mid-1960s, and the research has shown that the best management of ovarian cancer in this setting is a combination of surgery and chemotherapy. And many of you have probably sat in clinic rooms and had a conversation about how we use these two treatments in combination. The timing is less important than the success, if you like. So sometimes people will have chemotherapy and then surgery and then some more chemotherapy, and sometimes people will have surgery and then all of their chemotherapy. And the way we make those decisions will be based on a variety of things: people's fitness, where it looks like might be involved on the scans, what the operation might entail, and then we make a decision as to what the safest and likely to be most effective approach and timing is for that patient. And then the goal would be complete or maximal removal of any visible ovarian cancer at the time of surgery, which we would do through an up and down incision on the abdomen, and it's open surgery, not keyhole surgery conventionally. It can be very extensive surgery. It can involve removing part of the bowel or the spleen or part of the diaphragm, which is up near the chest. The complication rates are relatively high, but most of those are minor complications. The average length of stay is anywhere between 4 and 14 days, and the average time it takes to do an operation like that is in the region of about 2.5 to 5 hours. A lot of the research has focused, more recently on how we can make this surgery safer, because, as I've just said, it's not without its risks. And so, I hope I don't offend anyone by the use of the word the typical ovarian cancer patient, because there is really no such thing. But when we talk about patients presenting with advanced ovarian cancers that are going to be looking at having this maximal effort surgery, often the typical ovarian cancer patient is in quite a vulnerable cohort of the population. And that's because about almost a third are over 75. 70% are malnourished at the time of presentation. Many have other medical problems that interplay with how they're going to deal with this treatment. 60% score highly on our frailty scores. 40%, understandably, are suffering with anxiety and depression, but that I'm surprised it's not higher. And as I've just said, there's a high risk of complications related to the surgery. And so a lot of our efforts, research-wise, focus on not how we do an operation, but how we can make it safer, how we can make the recovery better, how we can make people's tolerance of that surgery better. So preoperative interventions are designed to empower patients to maximise their resilience to the treatment that they're going to have and improve their long-term outcomes for that. So some of the research work is focused on the malnutrition, which is obviously a big problem when people present. We know that having malnutrition increases the complication rates, it reduces the success of the surgery, it prolongs the hospital stay. All of those things lead to poorer outcomes and poorer survival. They're more likely to have other problems like anemia or kidney disease. And studies have shown that preoperative intervention, if it's identified and we do something about it, can improve how patients tolerate their surgery and how they do. There's not a huge amount of studies looking at dedicated interventions, but what we have suggests that this is best addressed with a multimodal approach. So we don't just look at one problem in isolation, we address all of the factors that mean patients might not tolerate their surgery very well to optimise them for this huge obstacle that they're about to try and climb. So what we know with a multimodal approach is that it needs about a minimum of 2 weeks, and the multimodal aspect of it refers to addressing any respiratory issues and smoking cessation, trying to stabilise or increase weight to address the malnutrition aspect, exercise and mobility, optimising any other medical conditions, and psychological interventions to provide support where it's possible to. And what we see from the research studies is that multimodal approach improves functional capacity, which we can measure using tools like a 30-second sit-to-stand test, where they get you to sit and stand as many times as you can in 30 seconds, which I don't know how many times I could sit and stand in 30 seconds, so I don't actually know what the benchmark would be. We see reduced depression and anxiety scores. 71% of patients manage to stabilise or improve their weight. We get a reduced length of stay after surgery, fewer post-operative complications, and we shorten the interval between finishing the operation, going home, and starting the chemotherapy treatment. So that's how we can make surgery safer in terms of patient fitness, but another way we can make surgery safer is, and improve the outcomes from it, is by improving the quality of surgery. And so there's various stakeholders involved in trying to do that. So the Royal College of Obstetricians and Gynaecologists has a key role in quality control of surgeons and in the training centres that train them, and ensuring that we develop an appropriate curriculum so that everyone's appropriately trained to deliver the surgery that patients need. There are other national organisations and collaborations such as the British Gynaecological Cancer Society, and they work closely with the charities like Ovacome, and we have collaborations also with colorectal surgical societies to quality assure the surgery that's being done and the training that's being delivered to doctors in training. There's also fellowships available nationally and internationally to try and maximise people's surgical skills and then get them to disseminate that amongst other units. And this, as I mentioned, the European Society certifies high quality ovarian cancer centres. Although I would say if a centre doesn't have ESGO certification, it doesn't mean they're not providing high quality cancer surgery. It might mean that they don't have the same number of patients, or they haven't had anyone who's put in an application. You know, so I don't think it should cause alarm that you're being looked after in a centre that doesn't have that. These things are all skewed towards larger centres, and they're skewed also towards larger centres in Europe rather than in the UK because of the way that they assess things to give that award. There's also a lot of work ongoing in addressing variation in outcomes. So work that's been done in recent years has shown that there is some variation in outcomes nationally, and that's never just down to one thing. That's never just one surgeon or one area or one hospital or one chemotherapy unit. It's always multifactorial. And there's lots of things that will be related to those outcomes. So the population health, the population's access to healthcare and how easy they found it to get seen in a timely manner, the surgical approach at the hospital, the proportion of patients that get any treatment, because we see that varies, the proportion of patients that present as an emergency or get diagnosed kind of more electively, because we know that presenting as an emergency is associated with poorer outcomes. And so the National Ovarian Cancer Audit was run as a pilot and is now a permanent fixture, and that's collecting registry data of every unit in the country and providing us quarterly reports on ovarian cancer management with age, ethnicity, how patients accessed their diagnosis, what proportion of patients got surgery, what proportion of patients got chemotherapy, and what the survival outcomes are. And that's an iterative process. They're going to build more and more factors into that report as time goes on. But that's a really key way in helping us identify areas for change and areas of good practice and try and balance things out as best we can. And there's also work that's been championed locally. The IMPRESS study by one of my colleagues, Richard Edmondson at St Mary's, was involved with this, and this has been looking at MDT decision making and how that relates to surgical outcomes and survival outcomes. And they're also developing data-driven and machine learning tools to help provide personalised decision support tools. So, you know, what women with ovarian cancer may see in the future, in a few years' time, they may go to clinic and they may be shown, you know, a package that says, well, actually, we've put in all of your numbers, and this says that for you, the best treatment is this. It's just a more focused, more personalised approach at identifying what the best treatment approach is for patients. Which I guess brings me to what next. And I think, you know, we're at a very exciting time in ovarian cancer management. We've made drug-wise, huge changes in the last 10 years. I'm sure Professor Jason will tell you about them in detail next. But surgically, we haven't made huge changes. 10 years ago we were championing maximal effort cytoreductive surgery, and we kind of still are. And that has been the right thing to do. But in terms of what the future holds, I think next year we'll see the publication of a study called TRUST, which has been probably the most robust, unbiased study of the importance of surgery in the management of ovarian cancer to date. This is unpublished, but I suspect that what those results are going to tell us is that it's going to more clearly outline how surgery timing is going to affect patient outcomes. I think it will reinforce the importance of removing all visible disease at the time of surgery, and that will be more important than when you have your surgery. So my expectation is that will result in more women having interval surgery after their first 3 cycles of chemotherapy than having primary surgery. But I suspect that surgery will remain the standard of care, with and the goal being removal of all of the disease as far as we can. And the goal then is going to shift to how do we predict that, because what we want is to make sure that we're continually increasing the proportion of women that are having surgery and we're removing all of the visible disease. There's work ongoing looking at adjuncts like intraoperative chemotherapy, HIPEC or PIPAC, and it may be that becomes part of surgical management in the future, but it remains to be seen. The data has been mixed, and we don't yet have a position statement from the national societies on whether that's of benefit or not. There's been some feasibility work looking at whether there might be an opportunity for a minimal access approach for ovarian cancer surgery, because historically it's always been a huge operation or a huge operation, but maybe for some people there's a choice. There's ongoing development of personalised kind of decision-making support tools. And so I think I've told you everything I wanted to tell you. I haven't said much about surgery for recurrence, but I'm happy to talk about that in more detail if that would be of interest to people. I don't have any slides on it, but I did mention it on one of the slides about what the potential goals of surgery might be. So increasingly, I think there's a place for surgery for recurrent disease, and what we have seen with the data that's come out of research studies is that we now have a really clear idea of who's most likely to benefit from surgery at recurrence compared with who is not likely to benefit. And sadly, what we're talking about in terms of benefit is who is going to survive longer if they have an operation compared with if they only had chemotherapy. And so there have been various studies that have shown us that if we can quite well select patients in whom we should get a good result at surgery for recurrence, because the evidence tells us that we need to be able to remove all of the disease that we find, or there isn't a survival benefit, a survival advantage of having that operation. It's just another operation to recover from, which doesn't give people more time. But the most recent study that's given us good data for this is the Desktop 3 study. So we regularly review patients in our MDT meeting where we will review their history, their current scans, and we'll decide if the disease picture that they've got at the present time is something that we would be able to remove in its entirety if we did another operation, because we know that we can give people a significant amount more time if we can do a successful operation. Thank you very much for your attention. Thanks for having me.
So, before we take questions,